The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. Good evening and welcome back to another episode of the Success in Practice podcast. Today I'm joined by Professor Lainey Cameron. She's an osteopath and an exercise physiologist with 30 plus years of clinical experience. She is also a researcher and an educator across 2 continents, working across private practice, hospitals and university clinics. She, as of June 2025, has ceased being, at the University of Southern Queensland, where she was the program leader for the Bachelor of Sports and Exercise Science in Clinical and Exercise Physiology. And she's now at Southern Cross University. Lainie loves being outdoors, engaging in endurance activity, working on projects over a long time, and including animals, therapy dogs and horses in her clinical practice. As I said earlier, she has recently commenced in the role of Professor of Osteopathy at Southern Cross University. She really enjoys mentoring people, helping them to reach for their best. That has been her inspiration for teaching and also the reason why she has taken on this new position at SCU, which we will talk about in this podcast, amongst other things. Lainie, thanks for being on the podcast and welcome.
Thanks, Sami. Glad to be here.
Often a few osteopaths reach out to me. We have a chat about certain things, and they ask me about the podcasts, and a few of them would say, like, what's coming up? And I'll tell them about some of the guests that I've got coming up. And your name came up from the time that we booked this, which was a few weeks back, and they were genuinely excited. You seem to, they were like, oh, wow, I can't wait for that episode. So there's a little bit of excitement and people are looking forward to listening to what you have to say. So thank you for being here.
You're welcome.
The biggest interest from people seems to be the background of osteopaths and how they became osteopaths and the kind of people they are. So let's start with that. Tell us about your background story. Tell us about, your childhood, growing up, where you grew up, family life, school life. What led you to, probably exercise physiology first and then osteopathy? Tell us about that journey.
Sure. And actually, it was the other way around.
Right. Okay.
But that's okay. Look, I grew up in the Blue Mountains, west of Sydney. I lived there until I was 13 and a half. I knew very early on in my life that I wanted to work in healthcare. One of the first projects I ever did at primary school was on the health services in my region. I was always a bit of a nerd. I moved to Melbourne as a teenager. That was my father changed jobs and we all moved. And when I was finishing high school in Melbourne, I probably drove my mother a bit bananas, sitting there with the VTAC guide, reading out all the possible health programs I could possibly go and do. There were very few areas I wasn't interested in. And it was when I read out the osteopathy program at Phillip Institute that my parents both said, oh, that'd be great. You could do that. And look, my family knew about osteopathy because my father used to have acute episodes of low back pain that would immobilize him. And he would end up lying on the floor in our house, not able to move. And in Springwood in the Blue Mountains, there was an osteopath who would do house calls. And Dr. Whitehouse would come and see my dad. And it was almost miraculous that, after Dr. Whitehouse had been to visit, Dad could get up and move around again. And then he'd obviously need to go and see him again for a couple of appointments, but he was mobile. So he'd go from being immobilized to being mobile. And I got to see that as a child. So yes, my parents' excitement around osteopathy being something that I could do and a health field I could go into was obviously influential. My mother used to always tell me I had good hands. I'd brush her hair or massage her scalp or something like that, and she'd say, "You've got wonderful hands. You should do something with your hands." And so there was lots of parental influence. I went to Phillip Institute, as it was then. It was Phillip when I started. It was RMIT by the time I graduated. I was in the final cohort of students to complete the original 5-year bachelor program at RMIT.
What year was that, Lainey?
That was 1994 we finished.
Right. Okay.
So with an internship as part of that program. So I went and did my internship with John Pitcher. You've interviewed John.
Yes.
And,
good man, John.
And I think I was the first associate that John put on. I know Gary Fryer spent a little bit of time with John in the same internship, but I think I was the first one that John put on for the whole 6-month period of internship. And then I stayed another year in practice with John. And then that position was really a graduate job. So I was very fortunate to have an ideal role to allow me to transition from university into clinical practice. The combination of an internship and another year working with a mentor as skilled as John was brilliant.
Right. You mentioned that from a very early age, your parents said that you had great hands. Your parents really encouraged you to follow osteopathy. When you finally got to the Phillip Institute, as it was known back then, when did it really, I mean, we think we kind of know what osteopathy is, and then we actually do osteopathy, and then you really get, you get the baseball bat to the head about how deep this thing can go. When was the aha moment for you? When did you kind of go, you know what, I'm all in on this. This really makes sense. Like when did the penny click? When did the penny drop?
I think I was all in from day one.
Yeah.
But I was also sinking or swimming,
right.
from day one. And that transition that you talk about, Sami, where we go from being outside of the profession, but thinking about it, attracted to it, affirmed by family and friends that this would be something good for us, to that overwhelm that comes in first year when you're hit by how both broad and deep this knowledge is that you're probing into. That is a really common and normal transition in all of the health professions, and I would probably stretch that to all of the helping professions. And so maybe my entry to osteopathy initially was a little bit like, Milhouse in The Simpsons. My mum thinks I'm cool. My mum thinks I'd be good at this. And I can't say that I was good at it from the beginning, not at all. I was as overwhelmed and treading water madly as every other student. But I was also completely in love with this.
Was there any particular moment that you remember or anything? It might not be that moment that you started, but was there any kind of like
I remember a moment in first year technique class with Cynthia Tucker, and we were palpating erector spinae muscle belly and just doing cross fiber inhibition to the erector spinae. And she wandered around the room and checked on each of us. And we were all scared stiff of CT. She was a very frightening lady. And she walked up and she looked at me and she looked at what I was doing. And then she looked at me and she said, "You do have some idea about this, don't you?" And walked off. And I kind of went, "Oh, okay, maybe I could do this after all."
Good. Yeah, right. And I mean, at university, you mentioned Cynthia Tucker. You said you did your internship with John Pitcher. Were there any other major influences that you kind of look back on and just are grateful that you had that connection with somebody who might have been a mentor or a teacher?
Look, there have been lots of fabulous teachers over my time. John and Cynthia both stand out as class acts in osteopathy and in my osteopathic education. But there were lots of good, dedicated, devoted people teaching in those programs, and I think we've still got lots of dedicated, devoted people who really want to give back to the profession.
Who was the head of the program at the time, Lainey?
Cynthia Tucker was the head of the program for most of the time that I was at RMIT.
Yeah, and when you graduated, had Ray Myers taken over then, or is that
No,
that came
Ray and
later?
I were actually in the same year level. So I
Right.
graduated
Okay.
with Ray Myers.
Great.
Um, Ray was a wonderful human and, yes, a really positive influence. But for me, he was a peer rather than a mentor.
Yes, yes, yes. Okay, so you mentioned that you completed the internship with John and spent a year there. That obviously, from your tone and what you're telling me, was quite an influential time for you as a young practitioner. How influential do you think those first 2 years are in the life of an osteopath in terms
I
of?
made so many mistakes, Sammy.
Mm,
I got burgled in that first year in practice. Um, I, or rather, I let John's practice get burgled is perhaps a more
right.
accurate description, right? And John comforted me and supported me and didn't sack me.
Mm,
You know? um, I, I I directed a patient to leave in
mm,
that year. The patient propositioned me, and um, I turned him down, and then he pushed again, and I just told him to go. And so he got up and he walked out, being very angry with me. And then, of course, I had to tell John that I'd lost as a patient. And again, he was just amazingly supportive. I remember him saying to me, Lainie, there are some patients we don't need.
yeah, that's not a big loss at all.
Um, yeah,
Yeah, right.
I yeah
When did
can't
you when?
speak highly enough of the support and the guidance and the mentorship that I was given as an early graduate,
Mm,
um, and the permission to make
yeah.
mistakes, not encouraged to make mistakes.
Mm,
High standards were always upheld,
yeah.
striving for excellence. But at
Yeah.
the same time, you screw it up, and the person mentoring you, guiding you, supervising you, gives you permission to make those
Yeah.
mistakes and learn from them. So
Yeah, and
yeah,
hopefully helps you learn from them. Uh, when did you finally hit your stride, do you feel? I mean, like that's a very, objective or subjective thing, but when did you think that you kind of hit your stride and started to feel comfortable in your own, I guess, osteopathic skin?
oh, oh, that's a really challenging question, Sammy, because I would say I'm
you,
fiercely loyal, but I'm
yeah.
also easily bored, and so I can have continuously sought out new challenges
Mm,
in osteopathy. And what that means is that I often haven't spent long in one place,
mm,
uh, in a clinical environment.
mm,
I've spent a long time in particular university environments, and I've always had a foot in each camp. I've had a foot in practice and a foot in the university,
mm.
uh, for virtually all of my career now. So I've had different levels of comfort in different places at, at different times.
Maybe to
Um,
make that question a little bit, I guess, easier for you to answer. Sometimes we, as a young practitioner, obviously when we look at our day, we might get a little bit of kind of anxiety or some kind of not overwhelmed, but we kind of get that little bit of a spike in adrenaline just waiting for that patient to come in who's a bit challenging. When did you just feel maybe more confident about your day-to-day work rather than hitting your stride? When did you start to become a little bit more confident, a little bit more comfortable that okay, there might be challenges today, but I got this. I can handle this. When did that start to happen? Was that 1 or 2 years into practice,
Yeah,
5 years into
probably
practice?
more in my second or third year out. Um, I, after working with John,
Mm,
I worked at Brighton Spinal. I initially did a locum for Cynthia Tucker, which again was an enormous compliment.
mm,
She cornered me one day when I was tutoring with her at Victoria University.
mm.
So she was my introduction to academia too. I was her sidekick in practical classes initially as a casual. And she cornered me after one class and she said, I've got a really sore neck. I'd like you to treat me. And I did. And then at the end of that, she said, thank you. I feel much better. Would you come and do a locum for me? I'm going to England for 6 weeks.
I thought she was going to say to you, I've got a really sore neck. Can you come and locum for me? I'm taking some time off.
No, she made me treat her first. And
Okay, good.
then she offered me the locum job. I had no idea she was sussing me out for a locum job until after the treatment was over.
Yeah, well, that's the best interview process. I think
Yes.
we get
And
caught
so I
up
did
in.
that 6 week locum. And at the end of that locum, that then became, look, could you please stay on?
Yeah.
So I then stayed on at Brighton Spinal. And that was a
Mm,
multidisciplinary clinic with medical practitioners, musculoskeletal med docs, some
mm,
physios. They now have exercise physiologists there as well. Uh, and that was a lovely next step to broaden
mm.
my
So,
skills.
would you credit then your, I guess, your confident? You said, you had a little bit more confidence in that second and third year. I guess, would you credit that to just the volume of patients that you accrued over those first couple of years? Would that be key to kind of just seeing more hands-on, different people, different tissues, different problems?
Stuff you've seen before. Yes,
Yeah,
yes,
yeah. Just
absolutely.
rinsing and
There's a,
repeating and
I've been around this before.
yeah,
Yes.
yeah, great. And I guess then what led you? I mean, we're going to talk about osteopathy for the greater part of this I guess podcast or interview. But what then led you to exercise physiology after that?
Well, I started in academia, as I said, quite early,
Mm,
initially as a casual tutor, like many osteopaths do. And then Victoria University had a level A, that's an entry level academic position available, and that was offered full time or part time if we could find people to job share. And so that position was initially a job share with Vicky Lee. And so Vicky and I worked together as the two halves of that appointment. And I uh, realised very rapidly that the VU program was a bachelor's and a master's program, and very soon I was going to be involved in teaching students who had a degree that was awarded higher than my own.
mm, right.
So I cracked on and got a master's. So I did my master's by research to start with, and that was in osteopathic education. I looked at what we train osteopaths to do at university and then what they do in practice and how closely those two things matched.
Okay.
And I looked at that internationally, split the world up into 5 key regions at the time.
Okay.
Uh, and that then gave me a qualification that was technically higher than the students I was teaching, because it was a master's by research and they were coming through a master's coursework osteopathy program
Hmm.
with some research components in it. But I also fell in love with research in that process. And I had a fantastic supervisor. So my supervisor wasn't an osteopath.
Mm,
Osteopathy at that stage didn't have a lot of people with PhDs who could
yeah.
supervise. So my master supervisor was Mark Anderson, Professor Mark Anderson. He was Dr. Mark Anderson at that stage. He's a sports psychologist,
Mm,
and I had osteopaths on my sort of cheer squad who gave me guidance and advice. Dr. Peter Gibbons was my co-supervisor, but it was Mark that I worked most closely with to learn about research and earn my stripes as a researcher. So when that was done, I took on a PhD, and my PhD was a series of linked clinical trials. So for a whole lot of other reasons, I'm really interested in rheumatology. And my PhD, I looked at manual therapy and exercise using the GOT sequence as a standardized approach to manual therapy, and Arthritis Victoria's WAVES program as a somewhat standardized approach to exercise.
And just to clarify, GOT is the
General osteopathic
technique. Yes.
You interviewed Anne Cooper a while back, and she spoke about it. So, yes, general osteopathic technique, an approach, essentially articulation,
a standardized
mobilization of the whole body in about a 20-minute sequence.
Okay.
And we were, as a undergrad, that had been drilled into us. So it was a procedure that I knew well. So I used that in my research, and so I had a series of linked trials looking at using an osteopathic intervention and an exercise intervention, initially independently and then together in people with osteoarthritis or rheumatoid arthritis.
Okay.
Varying results.
Yep.
But that meant that my PhD really has, again, a foot in each camp. It has a foot in osteopathy and it has a foot in exercise. So at VU, I worked my way up and progressively threw my lot in more and more with academia and with research, from a level A to a level B to a level C, which is a senior lecturer. And then in 2006, the Australian healthcare system opened up a little bit, and exercise physiologists were included in Medicare. That, for exercise physiologists, meant that their programs now needed to include broad-based training and couldn't specialise from the beginning, because EPs were becoming primary contact allied health clinicians. At Victoria University, the exercise physiology program was led by Professor Steve Selig, and Steve's expertise is cardiac rehab. So VU went looking for someone who could teach the musculoskeletal component of their program. And I jumped from the osteopathy unit to the exercise physiology unit, but as an osteopath.
Right.
And then I was effectively grandfathered in as an exercise physiologist over the next 3 years.
Okay.
My PhD gave me some formal qualification there, and then I had quite an extensive range of professional development that Exercise and Sports Science Australia also assessed to then give me my exercise physiology accreditation.
Okay, so it wasn't like an official degree or something that was...
So I don't actually have an undergrad qualification in exercise and sports science.
Yeah.
That is, as you suggested in the beginning, actually a much more common pathway.
Yeah, right.
There are several osteopaths who've been through that pathway of starting in exercise science, maybe even finishing an exercise science degree, maybe even finishing the clinical accreditation, which is exercise physiologist, and then going on to osteopathy. But I actually went the other way, and the amnesty program that ESSA had available at that time no longer exists. It didn't exist when I started in the EP program. I came in as an osteopath with musculoskeletal expertise, and then this opportunity arose, and I jumped at it.
It sounds like they created it for you. Sounds like they created it for you.
Since.
Yeah.
Sorry, what did you say, Sami?
It sounds like they created it for you. Like it didn't exist then, and it doesn't exist now. I mean, there's plenty of pathways now. They didn't just create
it for me. It was about a change in exercise physiology at the time, that there were a whole lot of... It's Australia's newest allied health profession.
And it seemed like...
And there were a whole lot of people who needed to be grandfathered through. Yeah. And I just happened to jump on that bandwagon at the time.
Yeah, it seems like it was a necessary thing for that profession to kind of fill in the gaps they had.
That's right.
And not as a very smart way to do it. So I guess then, whilst we're on the subject of exercise physiology and exercise in general, you've told us about, I guess, your time as a young practitioner, and we've explored that. You have a background, I guess, now, or I guess you're an osteopath that kind of got taken on the exercise physiology journey, how do you think osteopathy should approach exercise within the framework of the system of medicine that is osteopathy? And let me open this up for you so you understand the question that I'm asking specifically. It doesn't seem like we really have an approach to exercise within osteopathy. It seems like we do osteopathy and then we go out and we become strength and conditioning coaches, or we become exercise physiologists, or we go to a course about training, or we do clinical Pilates, or we do. It's not really thought through the lens of osteopathic philosophy, principle, and so forth. We haven't really. I don't. I haven't. I've talked to a lot of people, and although there are individuals that I've talked to that do see it through that lens, me included, and other people, I talked to Matt Harris and a few other people of like him who kind of see it through that lens. Um, and speaking to other people like Ann Cooper, for example, her stance is that the medicine is osteopathy, and then we increase tissue resilience after that improvement happens. And so I want to get your take on it. Like, how do
Mm.
you see us as a profession? Like, I see the physios have their thing, right? Chiropractors seem to do chiropractic, and then they take exercises from different kind of other professions or other modalities and add them to their. We're still a young profession in that sense that we haven't really gotten together and really thought about this properly. Um, Give me your take on it. How do you approach it? How do you see exercise in the clinical setting through the osteopathic lens?
I don't think I've ever seen exercise outside an osteopathic lens. So I'm just going to give you my perspective.
Yeah.
Uh, I don't know how to stop being an osteopath. I I do think that one of the challenges we have in osteopathic practice without exercise can be passivity.
Hmm.
That patients can come in, lie down, and expect us to fix them.
Yeah.
Uh, and that's not great practice. It's not good for us, and it's not really good for the patients.
I agree.
Exercise is a really wonderful vehicle for engaging a patient in their own care.
Hmm.
Can you engage a patient in their own care without using exercise? Yes, you can, but
Hmm.
exercise is an easy way to do that because no one can do your exercises for you.
I guess the question is less so that do we use exercise, but more so how do we view its application in light of what we do as osteopaths. So, for example, just to give you, when we start breaking the body into body bits, into little parts and pieces, and so when somebody comes in with a hamstring strain, do we address the entire chain? Do we look at the entire system and how that's broken down? And then do we view the rehabilitation process as a systematic approach to the entire system? Or are we just saying, well, do, 4 sets of 6 to 8 reps on the hamstring curl, and then do, progressive return to sport and all this kind of thing. Another example would be, when we look at lower back pain, we've seen the trends of recent come and go. The whole transverse abdominis trend that happened, 10, 15 years ago was just blown to bits. And now we see another trend with multifidus kind of coming around and so we start blaming muscles and body parts and little bits and pieces. To me, that doesn't fit the way we view the body as an osteopath. And so, but we're teaching this stuff. There are osteopaths, promoting and teaching this kind of approach. And I'm saying that we haven't really thought about it as a profession. And that's okay. Maybe it's not up to me to kind of get the profession together to do that. But even as individual osteopaths, we should be thinking about it. And that's really the question for me is like, do you approach it in that sense as a let's just break up the body into little bits and pieces and work on it that way, or do we look at exercise and how do we utilize exercise to get the whole system stronger?
Yep. So I would say to you, I never break the body up into little bits. I work with people. I don't work with
Mm.
hamstrings.
Yeah.
All right. Always. I always work with people, and people, that body is a unit. It's
Yeah.
all connected. And so I'm always looking at exercise through that lens. And
Mm.
I would stretch the holistic lens further for you, Sami. It's not just musculoskeletal.
Yeah.
So that patient with the hamstring strain, they don't just need exercise for direct rehabilitation of that strained muscle, right? They may also have type 2 diabetes, and
Mm.
exercise is a really powerful tool for managing that.
Mm.
They may also have osteoarthritis in the hip and the knee, and exercise is a really powerful tool for managing that.
Mm.
They may also have cardiovascular disease risk, and exercise can modulate that risk.
Mm.
So I don't just look at one little body part and prescribe exercise for that. And so that also then probably leads me to tell you a little bit about how I then work in with dual accreditation, dual registration. I will see a patient for an appointment as an osteopath, or I will see a patient for an appointment as an exercise physiologist. I never put the lens of the other profession away, but the consultation is focused in one direction or another.
That's understandable.
I'm a bit frustrated sometimes to see osteopaths doing, 3 minutes of exercises at the end of a consultation and going,
Mm.
right, I've done exercise prescription.
Yeah.
How would you feel if the exercise physiologists did 3 minutes of shoulder massage at the end of the consultation and said, there you go, we've done osteopathy?
Yeah. No, I get that. And I'm the same. I book people in for a consultation that's purely, in the gym or
Yeah.
wherever I need to
But I
do the
don't
work.
think that means you stop being an osteopath in that
No.
moment. If you
No,
do
of
a
course not.
consultation that's fully in the gym or fully in the Pilates studio
Mm.
or in the pool or on the field,
Mm.
you bring your osteopathic lens with you.
Mm. Yeah, I agree with you, and it's just what we talk about though, and also what we see out there. I get a little bit kind of, I guess, disturbed or a little bit, uh, I get a little bit worried that we're starting to um, forego our osteopathic principles for the sake of, I guess, following the trends of how things are done through maybe other professions or what we see in I guess uh, you know I guess the pop culture of health and rehab. You
Let
know.
me suggest an alternative explanation to you, Sami,
Hmm.
and that is that I think we, and I mean humans,
Hmm.
can compartmentalize things, break things into small pieces to make them manageable. And so I wonder if that very compartmentalized, segmentalized approach to exercise is being practiced by people who are feeling a bit overwhelmed. I wonder
Could
if
be.
it's a stress management tool that they're using without realizing. And they're just going, I'll hit the exercise that is I consider to be the most important, the lowest hanging fruit, the biggest bang for my buck here, rather than taking that holistic osteopathic approach to things.
Yeah, you are right. The holistic approach is a little bit tougher to think about. It's kind of it's simple, but it's not easy. I always say, it's funny when you think about the osteopathic approach to rehabilitating lower back pain. It's actually a really simple approach, but it's often not an easy approach, if that makes sense. It requires for the person that's, I guess, coaching it or teaching it, to have a really good understanding of communication and what they're trying to achieve, and then being able to actually communicate that to the patient, and then getting them to buy in, and it's a totality it's a total picture overview of what you're trying to do in terms of the final goal, and reverse engineer that goal into then the actual nuts and bolts of performing the rehabilitation. So I get what you're saying. I agree with you. I think that people tend to, instead of looking at the whole picture, look at little bits of it and try to attack it that way. That could be, that could be an explanation that I hadn't thought about. I just wish that we'd have a little bit more of an appreciation of the holistic approach of osteopathy, the structure and the function, the regulation, and take that to the application of exercise. And you would see then a lot more. It would actually simplify. I think personally, it would simplify. It would simplify a lot of what we do. We don't need. I always say to patients, if I have to give you more than say 4 or 5 tasks along your whole treatment plan, I'm probably not doing my job properly. If I have to really give you, 10 things to take away, like a sheet, you get patients coming after surgery and they've got like, 3 A4 sheets that are just stapled together and there's 10 exercises on each sheet. And then you just go a big cross to that. And it's like, look, you only just start off with these 2, get those right, and then we'll add to it as we go along. I don't want us to go down that path where we're just handing out sheets to patients of things that we could be simplifying just by applying osteopathy.
The holistic osteopathic lens is not only simple but not easy because it's elegant and at the same time pays attention to detail.
Yes.
So that holistic approach is not an excuse for just stepping back and not taking in the detail, right? Or being scattergun and hitting everything.
Yeah, you're right. Yeah, 100%.
Hello, everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
All right. Well, I want to move on and I guess discuss education. You've got a lot of experience in that field. Osteopathic, and you mentioned this to me in our conversations, osteopathic education doesn't look like it did when we graduated. When you graduated in 94, and definitely when I graduated in 2003, which, but I think when I graduated and when you graduated are probably closer together than what somebody in 2003 would see versus somebody in 2025. And so in light of that, can you comment, I guess, I want you to comment on the recent historical changes to education that you feel have affected how we deliver the current university courses? And then I'll give you some follow-up questions on that. But can you run us through maybe the changes in education in the last 10 years or 15 years that have really changed how osteopathy is delivered at universities?
There's been lots and lots of changes, Sami. You're
Give us the
absolutely
main
right.
ones.
Look, there are key historical points in the Australian trajectory, higher education trajectory. One of the key changes was when all programs were required to become what was called HIMSS compliant. So it was a higher education integration system. It was intended to increase alignment between universities and make student transition from one university to another easier. And that model essentially said to all university programs everywhere, you need to have a fixed number of credit points, units, weighted equivalents in each teaching period to allow students mobility. So that dramatically changed the landscape in osteopathic education. As undergrads at RMIT at the time that I was there, we had ridiculous numbers of contact hours and multiple subjects and many exams squashed into a very short exam period. Those things were broad brush done away with the introduction of the HIMSS structure. So that was a big change for everyone. By the time you were at university, you would have had a HIMSS compliant structure where you basically had 4 units a semester in a 2-semester model. And most universities around Australia did that for a substantial period.
What would you say, just before we move off the HIMSS structure, what would you say were the significant changes, the effects, the outcomes that we saw from those changes? Like, what would it have done to the student?
The HIMSS shift was difficult for lots of osteopaths of my era and pre-me because they looked at students coming through in your era and said, these people have spent less time at university, fewer contact hours than I have, and they've got a higher degree than I got, but I think they know less than I know. Now, one of the things we're not very good at is remembering how little we knew and how much our confidence was shaky when we graduated. So I would question whether that rhetoric is truth. I suspect that when we graduate, any of us graduate, we don't know all there is to know. And then the longer you're in something and get good at it, the more you realize how little you actually know.
I guess it's less about what the student feels like they are versus the actual content that would have been delivered and the hours that would have been contacted. So in that sense, the hours were lessened and the content would have been just by default less because there's less hours and there's less credit points and there's less.
So the content's not necessarily less. So this is a shift that we've seen in education that began that far back, right? Which is that the way that content is delivered changed. So the shift is the expectation that students will do more outside of class time. Now, the rub is that not all students do more outside of class time.
Yeah.
But the structure expects that they will and that they should.
Okay.
And that is even more so now.
Okay.
Right.
Move us on then after the HIMSS. That was one of the first ones that you said was really affected how.
So that was a really substantial change.
Okay. And then any other changes that we need to know about?
Look,
I guess
the one that everybody talks about now, of course, is the pre and post-pandemic education. The pandemic certainly rapidly escalated our shift to much more online learning, more virtual and remote learning. Education had already begun to shift that way, but that shift really accelerated during the pandemic and has not substantially swung back the other way.
Right.
Now,
And what kind of effect does that have on such a hands-on course that osteopathy is
so
required to
there are
be?
things in osteopathy that can't be done remotely. Absolutely. All right. But what it means is that for universities that still deliver lectures, and some do, lectures are done like this. They're done online. All right. And then we have now in more recent times, we've seen universities lately, and so the last 3 or 4 years, really struggle with enrolments. We've got declining university enrolments across the country. We've got a cost of living that's fairly substantial. Universities are now an expensive place to waste time.
Okay.
So parents no longer encourage their young people to go to university for 3 or 4 years and just do a degree and find out what you really want to do with your life. It's too expensive for that. If you've got a school leaver who doesn't know what they want to do, you encourage them to go and get a minimum wage job for a couple of years and work out what they want to do with their life. Because, they'll still fluff around till they find out what they're doing, but they won't end up with a really substantial debt at the end of it. They might even end up with a few bucks in their pocket. Right? And they'll pick up some life skills and they'll grow and they'll have some maturity that they didn't have when they were 18 and leaving school. That's a huge problem for the whole of the university sector. So there's been really substantial changes across the sector in the last 3, 4, 5 years to try and address that. Right. And so you see places like Victoria University moving to their block model, Southern Cross moving to what they call their Southern Cross model. Right. These are shorter teaching periods with deeper engagement. Right. So it's short, sharp delivery of a unit of study. Right. Where students are focused on that thing for a short period.
Okay.
Right. You've also seen universities, Deacon's done it, Southern Queensland's done it, I think QUT did it, moving to trimesters where they're offering 3 teaching periods right across the year. Students can fast track their degree or they can spread their degree out. And those changes are also in response to lower student numbers and fairly high student attrition. And one of the key drivers of student attrition is cost of living.
Okay. I guess what you're telling me though, this is a broad university kind
These are sector-wide issues.
These are
sector-wide. This is not just osteopathic education.
Right. And yet, but osteopathy, the osteopathic education has to go along with all these changes. We have to go along. That's right. So I guess the problem there arises is that when focusing on one thing is not a bad thing. Like when you say, you're hyper-focused on a certain subject, that's not a bad thing. But I think when you're hyper-focused on a subject and then you forget about it, that's the bad thing, right?
And you're right. You're putting your finger on an issue that all educators are concerned about. So anatomy is the touch point for this in osteopathic education. We don't want students to do an intensive unit in anatomy in year 1 and then forget about anatomy.
Yeah.
You have to take that knowledge with you. And so another trend that you'll see coming up in education now is what's called programmatic assessment, right? Where we structure long, sequenced, ongoing assessments across the life of the degree for those things that we want students to carry with them. Because we need to teach in these shorter, sharper, deeper modules but there are things we don't want you to lose.
Right.
So programmatic assessment is the new change. It's
And
certainly
when
something
would
we're
we see
wrestling
that?
with in
When
all of the osteopathic programs around the country, to my knowledge.
Right. When would we see something like that start to be implemented across the board?
Without letting too many cats out of the bag, I know there are some publications in development at the moment about programmatic assessment and how we use it in osteopathic education. And there are educators around the country planning their programmatic assessment to roll out next year or the year after.
Okay.
Sorry,
All right.
not 2026, probably 27 or 28.
Okay.
My mind is already into 2026 in terms of
I get that.
universities.
Yeah. Okay, so you've told us about some of the historical challenges we've had, I guess, in terms of understanding some changes across university sectors and how, I guess, osteopathy has been taken along for that ride. What I do want to ask you is, and this is just a little follow-up question before I get to my next main question. University bureaucracy or hierarchy sits down with either the osteopathy head of program or whoever's in charge of policy or education. From your experience, when you discuss these issues, when you say to them, look, the block mode is great to focus on, but it presents these challenges that we don't want students to forget things as they progress through their degree. What's the care factor like from universities? Like, are they just kind of rolling this out? Do they understand that there are nuances across different courses? Some require a lot more attention to detail in terms of anatomy, physiology, neurology, and also, I guess, the hands-on aspect of building palpatory skill and developing that over some time. Is there like a care factor there from universities, or is it, look, this is what we're doing, you guys work it out, you need to come along for the ride with us? What's the care factor there like?
There's always competing demands. So, yes, sometimes there's a top-down directive. This is the way this university is going, and you come with us for this journey or you get off the train.
Okay.
Right? Sometimes that's the way it is. And some of those big structural changes are delivered that way. At the same time, every program has a program leader, a program director, a course coordinator. That language differs from university to university, whose responsibility is to advocate to management and senior leadership, executive leadership, the nuance required for their particular area. Right? That's part of the job.
Yes.
And so I would often say to my team, so I've been a program director, I've been an assistant head of school, right? I would often say to my team when they bring me these sorts of challenges, I'm paid more to worry more. This problem that you're bringing me is my problem, right? And my responsibility in that leadership role is to speak truth to power.
Right.
Yes, some universities have excellent senior leadership. Some universities have senior leadership that might care less, right? So, but the structure certainly allows for the program directors to advocate, and that's part of their job.
Thank you for clarifying that. I mean, that's just kind of reinforced in my mind that we need heads of program who have great experience in osteopathy. I think that's really important because it seems like if there are structural changes from the top down that work against our interests, that we need somebody who's heavily advocating for the interest of the profession and the graduating osteopaths, for them to have good clinical skills, good, I guess, just all around osteopathic skills and thought processes that are going to serve them well in either private practice or any other new pathway that's emerging. And so from what you're telling me, I that kind of reinforces my own view that we need to make sure that the people who are in charge of osteopathy programs have a real solid background in clinical experience. And that's an opinion now that's probably been further reinforced due to what your input.
That's probably fair comment,
You
Sammy.
know,
But I would also say we're also human. We're also fallible. So
oh yeah,
those
I mean,
those
yeah, I get
program
it.
leaders aren't going to get it right all the time. And you know, one of my former heads of school used to say, if you want to make everyone happy, sell ice cream.
Yeah, no,
Don't
I
run
don't.
a university
Yeah,
program, sell ice cream.
yeah, I don't think they're going to make everyone happy all the time, but I think
So,
that as long as the intent is there, as long
yeah.
as the effort is there, the outcomes may be out of your control to a certain point.
Mm.
And a lot of times they may be out of your control if there's a massive directive from top down. But I guess if the effort's there and the communication's there, and we can see that people are really advocating for the best for the profession, I don't see a problem with that. And yeah, I mean, we've had examples in the past of people doing that. We've got some good current examples, and I think we've got some examples that could do a lot better. But that's for another conversation. I guess now that you've given us some of the historical aspects, and I've asked you about the university care factor for what we go through. My next question on that is that I guess, well, where do you think we have it right at the moment with osteopathic education? And what do you think could be done better to serve the profession? Like, what are we doing well, and what can we do better?
Look, one of the things that I think we do well and we don't want to move away from is that we still have hands-on practical skill classes with small staff student ratios.
Yeah,
So yes, students are doing a whole lot of their learning of theoretical content, their discussion with each other, their exploration of case studies, they're doing that online, but they're still learning hands-on skills directly in a classroom with their peers and a comparatively large number of staff for the size of that cohort. Now, that's expensive for universities to deliver, but it's one of the things I think we do well. And so I would want to hang on to that.
definitely. Okay. Where do you think we can do better? What do you think we're missing at the moment, or maybe something that we're not missing, but we could probably do a better job at?
Look, I think an area where we really want more bang for our buck across osteopathic programs is the way that we use the research components of the master's degrees that we have.
Okay.
So we have master's programs, and that requires that they're awarded at what's called AQF 9, Australian Qualifications Framework Level 9. AQF 9 determines the depth of the content, but we embed an amount of research in those master's programs, and we can tend to expect students to engage in individual research projects that may be very challenging for students, not lead to publications, are challenging for the osteopathic staff team to supervise. So there's an awful lot of time and investment for not necessarily a lot of output in terms of publications, grants, osteopaths going on to research careers, or even enjoying research.
Yeah, I agree. We had
And
that.
so I think we really need to rethink that model.
Mm.
I also think there's a real challenge for us, and this is perhaps going to be a little bit more controversial. There's a challenge for us as an allied health profession, right? We're an allied health profession. We have effectively pay and condition parity with other allied health professions, right, under the same award.
Mhm.
And we have 4.5 or 5 year pathways for training. All other allied health professions have a 4-year pathway, and many of them have a 2-year postgrad pathway. And we don't have either of those options in osteopathy in Australia.
Okay.
Which means potentially we are competing for the same pool of students with a program that is longer. All right. In an environment where we have a high cost of living and parents saying to their kids, if you know what you want to do, go do it, but don't fluff around till you find out.
Yeah. I totally understand what you're saying, and you said it's a little bit controversial. So I guess I'm gonna push back a little bit, and it's not a pushback out of, I'm just gonna play devil's advocate for a minute. Speaking to people like Rudy Gerhardt, for example, who was teaching up at SCU and found that he couldn't teach anymore based on the fact that he felt that the content was being stripped down way too much for the quality that he wanted to bring to that university. And so, whilst we want to, I guess, be competitive in that marketplace of students, like you were saying, and I agree with you, I think we need to have some more robust models for pathways in terms of postgraduate, and if a midwife wants to become an osteopath or an exercise physiologist, there should be a pathway there where we have something in place where we can allow them to do that. I guess the question is then, are we when you do something like that, something has to go. Like when you
Yes,
something
it's a
has to
crowded
get cut out,
curriculum.
right? It's a crowded
Yep.
curriculum. Something's got to cut out. That's the reality of it. Are we cutting out the wrong things? Because it seems like we're cutting out the osteopathy. We're not going to cut out anatomy. We're not going to cut out physiology. We're not going to cut out neurology. We're not going to cut out, the science of I guess what we do. But it seems like we're cutting out the art of what we do. The philosophy and the principles, and I guess maybe some of the nuances that makes us osteopaths. And I guess the criticism from some of the people that I've spoken to on this podcast is that we're moving towards a monochrome type of practitioner, that the osteopath is going to graduate and look like a physiotherapist, and the physiotherapist is going to look like a chiropractor, and the chiropractor is going to look like an exercise physiologist, and we're all just going to be kind of this monochrome type of graduate. And so that's not a doomsday kind of theory, because we've seen it happen. We've seen the loss of, I guess, some of the osteopathy, some of the art in that particular when those changes come in. So can you comment on that? Like, when something has to come in, something has to go out. Or when we cut things down, something has to leave. Are we choosing the right things to cut out?
Look, I think there's a constant tension there, Sami, and I'm not sure that we have always got it right.
Yeah.
That's, harking back to my earlier comment that, program directors are human too. And no, I'm not sure that we do always get those decisions right about what to leave in and what to cut out. But there is a constant challenge for us there, a continuous juggling act.
It's a hard question. I'm sorry. I've given you.
No,
it's a really tough question.
And it's a constant review. So one of the things that all universities do now, and this is a TEXA requirement, I believe. So TEXA is the Tertiary Education Quality and Standards Agency, and they're effectively the authority for governing standards within universities. It's a TEXA requirement that we continuously review and improve what we do. So most universities do that by surveying students and staff and industry members, and there's a requirement in the standards that we also hear the patient voice in our programs and the voice of other health professions in our programs. So we survey all of these stakeholders, for want of a better umbrella term, about, are we getting it right? And, lo and behold, They don't all agree.
Yeah.
Students often, will tell us that they really liked the unit that they found easy or the unit that they found exciting, but that might not be the unit that they most needed.
Yeah, I agree. Yeah.
So,
Understand.
yeah, look,
It's a
there's
balancing act. I get
this
it.
constant
Yeah.
checking, reflecting.
Yeah. No, totally understand that. And like I said, it's a tough question, and it's not a question that meant to be answered with any kind of certainty. Definitely not. That answer will, I guess, change depending on the current environment. So I guess then let's play this out. Lainey Cameron is in charge of setting up a new course that will graduate osteopaths. What would that course look like, Lainey? How would it be structured? And how do you go about graduating an osteopath that is, I mean, at least ready for private practice? It's still the bread and butter of what we do, and yet agile enough to move into emerging new pathways.
Well, the first thing I'd say is that I wouldn't be doing it on my own. So it wouldn't just be the Lainey Cameron show.
No, I figured that out, but I mean, let's call
Yep.
you the czar and king or queen, I guess. Sorry, the queen of what's going on. You have some power, you have some sway. I
Yep.
mean, in an ideal world, how would you structure this? How would you create a course? And when I ask you this question, it's not just about what we'd love to have. What would we love to have that would actually work in the environment?
Yes. So look, I think if all bets were off and time and money and things were no object, I would probably tackle a program structure that was a bachelor's degree awarded with honours, with a genuine honours research option that allowed students at the end of 3 years to opt for a research pathway or a clinical pathway.
Okay.
Right. Now, that is the model that's used in many other allied health professions. And the reason I go there is because I would love us to be competitive in the current market. And I would love us to be seen genuinely as peers with other allied health professions.
Yeah.
Not because I necessarily think that a 4-year structure is the best. All right.
Okay.
I'm trying to be strategic about that. And I think if we're designing a new program, we want to be strategic.
Okay. Let me ask you a quick question on that then. If you decide to take the research pathway in that honours program versus somebody who took the clinical pathway, would they be offered the same registration at the end of it?
Yeah, now that's a really interesting question, isn't it? And that question would go to the accrediting panel, not to the program director. But
Okay.
obviously, you would want to try to come up with a program structure that allowed your researchers to also get their clinical accreditation. But we've got that crowded curriculum challenge, haven't we? All right.
Yeah.
And if you make space sufficient to do research properly, do you lose the space to do the clinical training properly?
Well, I guess a little pushback on that is that if you decide to do the clinical aspect and get your registration, if you then wanted to go into research, you would have to do extra work, extra training. And so why wouldn't the same be expected of somebody who went into the research pathway?
That's a very reasonable question.
Yeah. So I guess,
Yep.
I mean, yeah, I would see that if you went down the research pathway, I think that's amazing. But then if you wanted to actually treat and become a clinician, there would be some kind of, I guess, makeup that you would have to do.
Yep. And so there are alternate models you could consider. But the model I've just put on the table is one that is used widely across other areas of allied health right now.
If you were running a program, Lainey, what is the criteria you would look at when, I guess, hiring or looking for people to teach the students osteopathy? I mean, you learned osteopathy of Cynthia Tucker and John Pitcher and people of that caliber. They were largely teaching you technique, but amongst that teaching of technique. There were anecdotes, there was clinical experience. And it was like, oh, I saw a patient last week in the clinic and they presented with this and I did that. And guess what? They couldn't take a piss and they've been able to go to the toilet now. But, all I did was a lumbar roll, or something. And so, that's kind of exciting for a student to hear. When you're going to look for people to teach, when I say teach osteopathy, it's not just about teaching technique, it's about teaching osteopathy, and there happens to be this technique that we're showing you also. And so how do you go about hiring people to teach osteopathy? What would be your criteria?
So, look, clinical currency is really important. Uh, we spoke briefly before the podcast, Sami, and you expressed some concern about teachers who have not really been clinicians or whose clinical experience is limited. And I would say to you that students are not silly. Students can see through you in a heartbeat. And if you can't stand in front of the students and tell them about patients you've seen recently and give them genuine reflection from your own experience, they're pretty good at dismissing you very fast.
But they've still got to cop it for that semester, like that's the hard part.
And so I think students deserve better than that.
Yeah, I agree.
Right. Yes, it's a continuous challenge as to how we fit everything we want in the osteopath into the osteopathic curriculum.
Is it easier to hire an osteopath and then help them with teaching versus hiring somebody who's an academic and then trying to get them to teach osteopathy?
Remember that most academics are not hired because they're good teachers.
Sorry, they would be hired because of their research capacity, I guess, and what they're doing in research. But they often take on, I guess, teaching also at the university. They would teach students in the field that they're researching in.
So research in Australia is largely funded by what we call soft money. It's largely grant funded. And so your research only runs for the time that your grant runs. And that's a really difficult way to live as a researcher. So most researchers have shared positions. They have teaching and research appointments, and some of those researchers make excellent teachers, and some of those researchers make terrible teachers.
Using research is probably not the correct word. I guess there are people that may have an affinity for teaching. They just enjoy teaching. They enjoy teaching at universities, but yet they've got limited clinical experience. They've kind of maybe been in clinic for a few years, 3 or 4 years, and they say, you know what, there's a spot here at this university. They're looking for an osteopath to come in and either be clinical supervisor or be a teacher in one of the subjects. They take on that position, and it's not like there's 1,000 people applying to these things. It's usually not a overly competitive market. Do we look for people who have vast experience in clinic, and then because those people may not be aware of the technical aspects of teaching, the online presentation, the way things are presented, the curriculum, the assessments, the objective outcomes. They might be a little bit more old school in the way they might teach the way they were taught, which may not be the current standard. But yet maybe newer graduates who have been closer to the university structure, only out for maybe 3 or 4 years, decide to go back to university and teach. They may be a little bit more aware of how universities, I guess, present their material, and they may be a little bit more admired by the university structure. And so the question is it easier to teach those people how to be osteopaths, or is it easier to teach, say, an osteopath how to be a teacher?
Academia is often like trying to herd cats.
Okay. Expand, please. I haven't heard of cats, so I don't know.
So I think both of those things can be difficult.
Yeah, okay.
All right. Very experienced, capable clinicians can be delightful and entertaining,
Mm.
but may not be interested in learning how to use the technology we use in
Yeah, I
teaching,
agree.
the current systems. They may not want to write a rubric to mark their
Yes.
assignment.
Yes.
So, that is a bit like trying to herd a cat,
Yes.
right?
Okay.
Trying to get the experienced, wise old osteopath to
Mm.
go where the university structure now says you need to go.
Yes.
That
Yes.
can be really challenging.
Yeah.
At the same time, I completely take your point that we don't necessarily want osteopaths who jump entirely out of clinical practice
Mm.
very early in their careers and are book smart but not worldly wise.
Mm.
All right.
Yeah.
So I actually want a team that is broad, where
Well
we
balanced.
have
Yeah.
diversity of skills, diversity of experience. I would also like to have diversity of culture and background and wisdom in my team.
Yeah.
And I think there's a lot to be said for the part-time, the fractional appointment with a university, where you have some time in clinical practice and you have some time stretching yourself in this continuous whitewater that is the educational environment.
Okay, and I guess the last point on, the wonderful world of Lainey Cameron and her very great course. How would you go about, I guess,
I haven't even got to writing curriculum for you yet, Sami.
that's okay, that's all right. How would you go about, I guess, protecting the osteopathy in that course? It's something that when I ask people, usually the final question in the podcast is, what would you like to see happen in the next 10 years of osteopathy? And in most cases, everybody said, I'd just like to see the preservation of osteopathy in its classical sense. Like we want to see the philosophy and the principles preserved. We want to pass that on to the next generation. So I guess if you're setting up a course, Lainey, how do you protect that? How do you make sure that whether it's by people up top above you, pushing things down, or whether it's just by, I guess, serendipity, how do you make sure that that is well protected? How do you go about putting concrete things in place to protect that?
I'm going to go out on a limb here, Sami, and say I don't think that we protect it by locking ourselves into a private practice structure. Right.
Expand on that. What do you mean by private practice structure?
So,
are you talking about like an internship model?
No,
right.
The focus of osteopathy being a private practice, that what we're training people to do is be ready for private practice, because that's how osteopaths work. I've been an osteopath for, 30 years now, and I've worked in private practice. I've worked in multidisciplinary practice. I've worked in GP practice. I've worked in hospitals. I've worked in universities, and I've been seconded to an insurance company. And I've been an osteopath in all of those environments. And I think modern osteopathy is actually going to go across a whole range of working environments.
As it should.
So I think part of the preservation of osteopathy is actually about preparing graduates for a much broader array of areas where they can work, but bringing with them their osteopathic principles, that lens, that way we see the world.
Yeah, so I guess
into a whole range of environments.
Let me then maybe narrow in the question. You've mentioned that you don't think that, private practice is the only way that osteopaths work. I mean, it is definitely a major way that osteopaths are working at the moment.
It's a predominant way.
Right, but it's not the only way, and it's not going to be the only way in the future. And we'd like for osteopaths to expand into other areas. We'd love to see osteopaths, more osteopaths in hospitals and more osteopaths in, I guess, community care, more osteopaths in aged care and disability care and sporting, sporting areas and so forth, just different fields. I guess, how do you protect the way that osteopaths think more so than where they work or what they do specifically, but how they think? How do you protect that? Because that thought process is what really can take you to different parts and different, and make you effective. That thought process is what takes somebody who can work in private practice, learn some skills, work in private practice, and then keep the thought process, learn a whole new bunch of communication skills, and maybe work with an insurance company. So how do we protect the way that osteopaths think, or how would you do it?
I don't know that we structurally do protect the way that osteopaths think. I think that becomes the responsibility of the individual. And actually that it's not reasonable to expect that the structure that you work in will offer that protection.
Is it reasonable to expect that it's being taught?
Oh, absolutely, that it's taught.
Yes.
But
Right.
not that it's inherent in the structure that you might graduate to work in.
Yeah, no, I get that, but I mean, it needs to be passed on to the next generation. Like, we need to actually make it available for them to learn.
Yes.
Yeah, and I guess is that the only way that you think that a university course could move that to the next generation, is to actually just teach it, and then it's up to the individual to actually then apply it? AT still says something like, osteopathy can't be served on a silver platter. You've got to go looking for it and searching for it. And I guess, do you find that, I mean, other than just teaching the principles and the philosophy and some of the more historical, classical concepts of osteopathy, which seem to really do well with time, they age really well. Teaching it, is that something that we should continue to teach?
Well, it's not just, absolutely, it's something we should continue to teach. It's not just teaching. What we know drives learning. So we don't just want it taught, we actually want it learnt. And as you say, dug into, applied, so that students become graduates who carry that with them.
Yeah.
So osteopathic principles, the osteopathic thought process, the lens through which you view a patient or view the world, is another of those things, I think, that needs to be part of this overarching programmatic assessment that I was talking about earlier.
Yeah, yeah.
Right.
Okay.
It's not okay to have a unit in osteopathic principles in year one and then have students forget about that.
Yeah, you're right. I agree with that. I think it should
This is
permeate the
something
entire
that
course.
they need to carry forward, and
Yes.
they need to be asked to repeatedly apply and dig deeper into as they move into each year level of their training.
Well,
So that becomes a habit. I think there are other things we can do that with too. We can do that with research methodology, with evidence-based practice. We can do that with clinical reasoning. All right.
Yeah, no, you've answered the question, I
And
think, just on
anatomy.
that last point. Yeah. Okay, so getting access to new courses, I guess, has been a major challenge, and a massive bottleneck for the profession. Getting graduates to get into my private practice has been a really big challenge. It's a big challenge, but one we actually need to overcome. Like, it's a massive sticking point at the moment, and if we don't overcome it, especially in some of the major cities in Australia, other than Melbourne, I think we're just going to really stagnate in terms of growth. We've seen what's happened in Melbourne in terms of the growth of osteopathy there. There's osteopath in every suburb in Melbourne, and I think that really lifts the profile and allows the profession to grow, and just it becomes part of normal conversation amongst people. Like, I went and saw the osteopath. It's just a normal thing that you do, and that's what we want. And I guess, what would be your advice to people who may have some responsibility for this expansion? What can they do better to get their foot in the door so that universities can listen to them, and ultimately we can have new courses in places like Sydney and Brisbane and North Queensland and Adelaide, and so forth, and some more regional areas too. We need growth in more university courses. How do you think we need to approach universities? What is it that we can do better? Because it's not happening at the moment. At least we're not seeing it. There's a new course over in Western Australia that's coming up. I think next year or 27. I'm not sure. I'm thinking like I'm in 26 already, but yeah, I mean that's happening at Edith Cowan University. How do we get it into the major cities? What is it that we're not doing that you think we should be doing? What can we do? Like how can we get universities to listen to us?
Sami, most decisions about a new program for a university are not made under the influence of an external party. Most of the time, what happens is the head of a school or the head of the faculty will be asked by senior executive, what new programs should we include in your school or your faculty in the future? All right. And if they don't say an osteopathy program is what we need here, it's probably not even going to get thought about.
I agree.
Right?
Yeah.
So the people that we need to be talking to about new programs are those heads of department, deans of faculties.
Mm-hmm.
All right. And we also need to be thinking strategically about how that new program would compare to other offerings in that school or that faculty. Hence my earlier comments about I would go for a 4-year degree awarded Bachelor with Honours.
Mm-hmm.
All right?
Yeah.
Because that's a current model that's already got traction. So when I go to a head of department somewhere and say, I'd like to put a Bachelor's Honours degree in osteopathy alongside your Bachelor's Honours speech pathology, Bachelor's Honours occupational therapy, it doesn't look odd. They have a fair idea of what it's going to cost, how it's going to roll out, what it will be like to staff it. There'll be some units that are already in common. So this looks like an affordable extension to the school or the faculty. All right. When we come in and we say, we need a 5-year program and it's got to be special in all these ways and we're not going to play with anybody else, we need to be the osteopaths and have it done our way, we look elitist and expensive and people don't want to talk to us. We've got to get beyond that.
Yeah, I agree. And so, okay, so then why do you think it's a challenge? Do you think we're not doing that at the moment? Do you think we're not coming up with course structures?
It's really hard to get the ear of deans of faculties and heads of programs.
I mean, it's not like universities are closed for business,
people,
right? They're not closed for business. New courses are popping up.
That's right.
Universities are taking on courses. It's not like, so why is it that other people can get their foot in the door? Why is it that, like other things or other professions seem like a great idea and we can't get our act together and put together some I mean, if you can come up with something that's going to at least make some money for the university, they should listen, or they could listen. What is it? It just seems like something's missing at the moment. I can't really put my finger on it, but can you help? I mean, what is it that you can add to that?
Hello everyone, just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes, so for more information, please see the show notes. Now, enjoy, and back to the show.
Look, there's a substantive lead time on a program making money for a university. So again, being realistic about that, you need full accreditation before you can enroll students. So you need staff on the ground writing your program, writing your accreditation before you can take any students in. Those staff need to be sufficiently supported. That's an expensive exercise. You're salarying people for, a couple of years before the program even enrolls students. You're adding new staff for those first few years that you are adding new students. So you're actually adding expense before you start turning a profit. There's a substantial upfront investment. So universities know that.
But again, that's the same with all courses. It's not just
the same with all courses, but we need to make sure that we are not more expensive than other programs in the same suite.
Yeah.
All right. And our current 5-year or 4.5-year models are more expensive, right? Because they're more time. So that's one thing that I think we could deal with. Right?
Okay.
Those heads of departments and deans of faculties, they're also relying on publicly available data. They're usually not having the ear of an osteopath who's saying, look, a program at your uni would be great, right? Yep. They're usually relying on publicly available data to tell them about need in the workforce, all right? Where's the data on that for osteopaths? Where's the data that shows that an osteopath returns this kind of benefit to Australia, saves the health workforce this amount of money? Where's that data that shows our impact at a public health level or a private health level? Because that's the data that then allows a head of school or a dean to justify putting a program together.
Is that data collected, I guess, through, I don't know, associations? Is it collected through, I don't know, taxation offices? I'm not sure. Like where do where do they get that data from?
So,
or do we bear responsibility on that? Does the profession take up responsibility?
I wonder whether we do. I wonder whether that's one of the things that we could contribute. Can we better inform Australia about
definitely
about the value of an osteopath or the value of the profession?
Yeah, no, I think we could do a better job there, and I think we need to have that data on hand. It's not like, well, we don't have this data. Well, let's go and collect it, because it should be done. Like, we should be doing it now. And so, all right. Well, thank you for that feedback in terms of university courses. That's interesting to me because I think we need courses. That's not debatable. But trying to get your foot in the door is always been a tough gig, and you've just explained why that is. That the structure of the course is important and the way that it's delivered, and we need to at least be on the same footing, if not probably a little bit cheaper than some of our allied health brothers and sisters. And so, I guess that answers the question, and I hope that anyone that's listening that can contribute to the data that we need is currently doing that. I want to ask you about maybe then some of the disconnect that exists at the moment between new graduates and practice principals, and I guess this was some of the research that you said you did in your earlier years about the you said you did it across 5 different regions, and just remind me, that was about the graduates and what the
So
expectation.
I looked
Yeah,
at what we taught in
yeah,
osteopathic programs at the time,
yeah,
all right? And this was, I completed that degree in 2000. So it's
right.
25 years old now,
Yeah,
right?
yeah.
Uh,
Things have
but I looked at,
changed.
a
Yeah,
bit's changed. We've talked
yeah,
about how the
yeah,
education landscape's changed
yeah,
in that time. But I looked at what we did in osteopathic education then
yeah.
and what osteopaths used in practice when they
Yeah.
graduated,
Okay.
all right?
So based on that, then I'll
And
ask
how
you this.
closely they fit, all right?
Yes.
And unsurprisingly, the US model of education with the full spectrum
Mm.
of medical practice available means that osteopaths in the US are taught a great deal, a really broad curriculum, and then most use a portion of that
Okay.
when they graduate. All right. In Australia at that time, we had a much broader curriculum than many clinicians used when they graduated.
Okay.
We've talked a bit in this podcast, Sami, about
Mm.
how things have been pulled out of the osteopathic curriculum because the time that students spend in class has reduced, and that's necessitated making some of those decisions about what we've lost.
Yeah.
Well, perhaps some of the things we've lost were okay to lose because, 25 years ago, we weren't doing a great job of lining up curriculum with the graduate's need.
Okay.
I haven't repeated the data collection for the modern environment. All
I
right.
wouldn't think that you have, but I guess
So
you would still have some experience and
now it would
understanding.
be much more and I reckon we're getting it right,
Yeah.
but it's,
So you
yeah.
think we're getting it more right now than what we were? I mean, do you think that at the moment, because I'm seeing a bit of a disconnect there between new graduates and practice principals, and I'm not saying that the disconnect is the fault of the graduates or the
And look,
principals.
I think this is a constant tension for us,
Mm,
Sami. I did a unit in biochemistry in my
mm,
degree,
mm.
including
Yeah, we did that
laboratory
too. Yeah,
classes in
yeah,
biochemistry. I struggled my way through it. I did
yeah.
pass because it was a
Mm,
degree requirement, but
mm.
gee, I didn't do well. Um,
And you haven't used it.
and I haven't used it, at
Yeah,
least not in a laboratory
mm,
biochemistry sense.
yeah,
Um, but it does mean that I do have a picture in my head of, what molecules look
yeah.
like. I understand structurally what a protein is and what a
Mm,
carbohydrate is and how and why
mm.
they're different. Uh,
Well, let's look at what the needs of a graduate's. I mean, you discussed and you
mm,
mentioned that there's obviously a lot of social pressure in terms
mm,
of cost of living and income pressure, and I guess what graduates ultimately want, from my understanding, is that they want to graduate into a profession that they feel like they can serve well, and that serves them well in terms of income and an affordable lifestyle. And so how do we go about, I guess, bridging that gap between whether it's private practice or whether it's going into, I guess, any other emerging field that's outside of private practice? How do we get them there quicker to a more sustainable income, I guess, and keeping them in the profession, like, so we don't lose them? Um, what do you think is missing? Like, what do you think we can do better at the university level to better prepare them for the real world of private practice, but also practice in other fields that osteopathy can be used for?
Look, one of the things that I have done with my students now for many years, and I think is really helpful, and they tell me it's helpful, is to share with them models of professional development across their lifespan. So I spoke at the beginning about how it's normal to go from that pre-profession excitement phase to being a bit overwhelmed and,
Mm,
and you said, struck in the head by how much there
Yeah,
is to learn, right? That's a normal stage of
it
professional
is.
development. There's another stage in the middle of your degree where you're drawing on lots of sources of influence, including your peers and your educators, and then you shift to becoming a bit more autonomous. And in that conditional autonomy stage, your confidence
Mm.
peaks and plummets
Mm-hmm.
repeatedly.
Mm-hmm.
And that's what those first couple of years in practice, whether it's hospital practice or private practice or any other
Mm.
setting, that's what they look like. You know, days where you think, this is great, I'm really good at this job, and other days where you think, I can't do a bloody thing right. Right?
Yeah.
And I have found that sharing those models of practitioner development with my
Mm.
students and letting them know that that is normal.
Yeah.
This stage of your professional development is normal,
Mm.
is a really helpful tool. And then helping them put around themselves sources of influence that replace those which they're losing when they graduate. So you go from being in this really rich environment where you've got educators who can guide you and peers who can be a sounding board for you, to often being one-on-one with a patient and maybe a boss.
Yeah.
And then maybe you call your best mate, right? So
Yeah.
your sources of influence have really shrunk, and you may be really over-reliant on them or concerned about being overly reliant on them. So I've also put together, you know, forums, Facebook groups, journal clubs, mentorship groups that support new grads
Mm-hmm.
through these transition stages.
Yeah. Amazing.
I think those things are really powerful tools.
In
Those
term,
first couple of years
yeah.
post-graduation, they're a bit like puberty, you know, like they're amazing and horrible and bloody hard work all at the same
Yeah,
time.
well, let's call them the heart attack, the ECG of the just ups and downs that you see. But I
Yeah,
think after, I guess the first 2 years, you're right, it looks like a heart attack. But then I guess from maybe year two, three to year six, seven, it should start to mellow out. Like that heart
yes,
attack, if that continues through your entire career, and that's not a place you want to be,
no,
No, right.
no.
So obviously this kind of
And
CPD that you need, 8, 9, 10 years into practice should look different than the CPD that you need in the first couple of years. So I agree with
yes,
you there, but let's go back even a bit further into the student life. Um, what role do you see for an internship model? You had it as a student. Do you think there's a role there for an internship model that, we're talking about a 4-year degree.
mm.
Is there something we can do as an internship that might expand on that 4 years, but then doesn't put a burden on the universities?
Yeah, look, placement poverty is a huge problem for students, a really substantial challenge that we need to deal with. And again, this is across all of our service professions, all of our health professions, and
Hmm.
then service professions as well, so teaching included, that students for the most part are not paid for being on placement. They need to do those placements.
Mm-hmm.
The expectations on them on placement are substantial, right? They are having that cyclic,
Hmm.
you know, sinusoidal fluctuations in confidence,
Yeah.
and they do need support and guidance through those placements. But they also just need to keep body and soul together. They need to keep
Hmm.
food on the table and fuel in their car and pay their rent. And we're saying to them, you need to go and do 500, 600, 700 hours of
Hmm.
placement for no money.
Hmm.
And sometimes you've got to do those a long way away from home.
Yeah. I guess
Right?
the placement makes sense when there's bang for buck.
So I think an internship model
Yeah.
has merit.
Yeah.
I found my internship really valuable,
Well, you got a job
but
out of it.
I got a job out of it.
Mm.
I had superb supervision.
Mm.
I had good bosses.
Mm.
Right. I had good opportunities. I spent part of my internship, most of it with John Pitcher, but I spent
Mm.
part of it in a walled hospital,
Mm.
a mission hospital in North India, 100 kilometres from the ceasefire line. And the university recognised that as part of my placement.
Yeah.
Um,
Okay.
so students need
A good internship model, Lainey, like if you structure it well, and it's obviously if we accredit the clinics that are doing this really well, do you see it as being a valuable tool that universities can use? Is it something that would be included in a course that Lainey would like to have, or is it a
I
nice,
think
is there a cherry on
there's
top?
room for a good internship structure. It needs the profession to be on board because, of
Hmm.
course, who takes those interns? Who pays those interns? And interns need to be paid.
I agree there
All
too.
right.
Yeah, they should be paid.
I did work for a while, so I've had a segue uh, in my profession where I worked for a while in medical education
Hmm.
in a hospital, and I worked specifically with interns. And there is an Australian curriculum framework for junior
Hmm.
doctors that is taught. So there's structured education throughout the internship year for junior doctors, and
Hmm.
then that carries on through postgraduate year 2, year 3. So the junior house officer and senior house officer years. To my mind, a good internship is not only paid and well supervised, it has a curriculum that underpins it.
Hmm.
So it extends your education that way too.
Yeah,
Um,
no, correct. You're correct on all
and
that.
look, interns are vulnerable. They're open to exploitation. So
Hmm.
we would absolutely need to make sure that an internship model did not exploit graduates.
Hmm. Yeah, definitely. Yeah, but I think it can be done right. Like it's not out of, I mean, other professions do it.
It's not impossible,
It's not
for sure.
impossible. Yeah. I want to move on and talk to you about research, and I guess research within osteopathy, because that's our what we're talking about today. What do you think should be the aim of research within osteopathy? And are we well aligned between clinical, I guess, what we're seeing in clinic and then what we're doing in research? Like, do you think there's an alignment there, or do you think that could be better aligned?
Look, research requires that we narrow questions down,
Mm.
and an osteopathic lens in practice, as we've talked about, is inherently about opening your view up.
Yes.
So it can often feel like there's a mismatch between what we do in research
Mm.
and what we do and see in our clinical work.
Yeah.
Um, Research is hard, and it's not appealing for
Mm.
everyone. I don't necessarily think that we need every osteopath to be a researcher.
Yeah, I
Hence
agree
my
with that.
earlier comments
Yeah.
about two pathways in a
Mm.
program, one that
Mm.
goes into research and one that goes into clinical work.
But do you think that clinical and research should be a little bit better aligned? Like, should we, I mean, not everyone should be in research, and equally, not everybody should be in clinic. But when we get really good clinicians that want to not just want to do research, but have something to offer research, how do we go about and saying, look, there's a clinician here that's getting some really good results using X, Y, Z, this particular approach. So how do we take them and then attach them to a researcher that can help them, or even take on that research and make it their own, and then develop their thought process? Like, it's a very rare thing where you find a clinician that then has a research brain. I interviewed Raymond Perrin a few weeks ago, and he's somebody that has a really good clinical background that turned that into a really good research kind of model, and then he's obviously done what he's done. Um, that's an anomaly. I think that's
I'm
not
going to
a
put
common
two
thing.
ideas to you.
Yeah.
And, because the best ideas are often pinched from someone else, these are both models that I'm lifting because I've seen them work in other areas. All right. Queensland Health has a model that they use with their allied health clinicians in the hospital sectors, in the health and hospital services, linking them with clinician researchers in the universities, because clinicians in hospitals often don't have very much time for research, and they don't necessarily have well-developed research skills, but they often have a question that bugs them. So they have
Yeah.
a research idea.
Yes.
And Queensland Health gets universities and allied health clinicians in hospitals together on a regular basis and puts them into collaborative teams, so partners them up. And I've been part of that process a couple of times, particularly in the Darling Downs Hospital and Health Service where I work, where I've been partnered up with clinicians that have a burning research question that could be undertaken in the hospital if they had some guidance as to how to design that project. So I think we could do that. We could partner up osteopaths with research interest with our academics in university and get more bang for our buck.
Yes, I agree
At
there.
the moment, we impose, as I said earlier, often a research requirement on our pre-registration osteopaths and kind of force them into doing research. And many of them do it very reluctantly.
Yeah, we had
could,
that problem. We had that problem
we
at
could
university.
shift that, and we could say, look, universities have got these researchers who are able to support you, interested, excited, who would like to partner with you so that you can then design a research project that you can do in your practice under the auspice of that particular university, using their research tools, including their ethics committee processes, and then academics can work with you to convert those results into a publishable format.
Well, you've seen that work in Queensland Health, and I'm assuming that's in the public sector where they yes, right. I mean, at the moment, most osteopathic clinicians are in the private sector. And
Yes,
so
which
that might
means
be,
if they take time away from seeing patients, they're losing income.
yeah, I get that, but that could be another area that the profession, that the association can kind of become more involved and bridging that gap between the people who are their members and and universities. I mean, that they could set up a database of ideas and internet forums and internet, I guess, online collaborations where you get together with people. I mean, you could just put an idea out there into a system. Someone picks up on it, and it's like a Tinder for osteopaths and researchers, I guess, if you want to call it that. You
Like
just swipe,
speed dating.
you just swipe left, till you find some question that you like, and that could be something that the profession could do.
So the other strategy I'd suggest is something that the Cochrane collaboration already does.
Yeah.
And the Cochrane call it task exchange. And it's Michael Fleischman, when I described it to him, said, "Oh, it's a bit like Airtasker for research."
Yeah.
And essentially it is.
Yeah.
Researchers will list on Task Exchange a discrete job within their bigger project. And they're seeking somebody to take on that particular part of research. So it's the alternative. It's not Sami coming to me with Sami's research idea. It's me going out to the osteopathic community and saying, I've got this research project and I need somebody to take on this little bit of it.
Yeah, right. Okay.
All right.
I get those two models.
For osteopaths who want to develop their research skills, that's a really nice way to step into research without the huge commitment of taking on a higher degree.
Okay. I guess to finally wrap up, where do you see some opportunities for osteopaths in the next 10 years, Lainey? And how are we shaping education to meet those challenges? Like, are we doing a good job in, I guess, utilizing? You talked about it in terms of the course structure. I think that's the big takeaway from today with regards to that, in terms of having a bachelor's with an honours program. That should be something that we look at a little bit more consistently across the board.
So
But
I'm going to
yeah,
circle back to something I said earlier about needing to look more broadly than private practice.
mm-hmm.
And I'm going to remind you of the Federal Health Minister recently having requested that all clinicians across the whole of the Australian health system work to the top of their scope of practice. That for the Australian health system to work properly, to work at its best, and we know that the health system's also under some strain, right? That we need all clinicians to be working at the top of their scope of practice. I think we need osteopaths to work at the top of their scope of practice. Right?
Where would that see osteopaths go? I mean, practically speaking, give us an idea of where you think then that might take an osteopath.
So musculoskeletal practice is where we predominantly sit at the moment. Musculoskeletal private practice, right? But we could have osteopaths in rheumatology units. We could have osteopaths in orthopedic units, right? I worked for a while, admittedly much more in my exercise physiologist scope, but in a surgical unit, in an outpatient setting, in a surgical unit, assessing patients before they proceeded to surgery, right? Using both my osteopathic skills and my exercise physiology skills. Right?
I think if you spoke to most osteopaths, they wouldn't disagree with you, and they would. I'd love to see osteopaths.
And so I think that needs to be one of the future opening up for the profession.
How do you feel that the profession
and not leave? I think we need to drop this idea that osteopaths who take a step into something like that are somehow leaving the profession.
No, I get that. I understand. But my question then is, how do we go about influencing that change? How do we go about? I mean, it's most osteopaths. If you tell an osteopath, would you go and work in the rheumatology department or the orthopedic department? They'd probably jump at the chance. It'll be just great experience to get your hands on people. And so, but I mean, there seems to be barriers to entry there. How do we overcome those barriers in terms of maybe, maybe they prefer physiotherapists, maybe they prefer exercise physiologists, maybe they prefer, how do we get recognition to be able to do that?
Must play well with others. Right? Must be prepared to dance up to the boundaries of your scope of practice and collaborate with others at those boundaries and learn from and with them.
Yep. Yeah, great. Okay. All right. Well, Lainey, it's been great having you on. We're almost at 2 hours. And we could probably talk for another 2 hours.
We might bore some people if we do that, Sami. Well,
only the ones that don't want to listen, I guess. But no, I think content is great when the content has meaning, and you've definitely given us a lot of meaning tonight. And I'm grateful that you've joined me. I'd love to do a round 2 down the track, especially as you sink your teeth more into this Professor of Osteopathy role at SCU. And so, I just want to thank you for being on the podcast. And stay on the line with me. But for everyone else, thank you for joining me again for this episode. And Lainie, thank you so much. And stay on with me, and everyone else, have a great night.